All right, so moved on from derm. We've covered our antibiotics. Now it's time to get into a different organ system. Let's talk about drugs you commonly see with ophthalmology. Here, there's a lot of infectious disease still, so I'm not going to belabor these points about the mechanisms of action for drugs we've already covered. I will assume you've not dumped everything from the first test, correct? I really hope so. Anyways, how are we going to be administering drugs to the eye? Yeah, so topical administration is most common, right? So we're going to talk, and when I say topical, I'm not just referring to the skin, I'm talking about topical as far as being on the external aspects of the body here, right? However, there can be more invasive varieties. So for instance, if you're working in an ophthalmology office, if you work with an ophthalmologist, you're going to find that there are other routes. Like, so for instance, we do a lot of subconjunctival injections and with our ophthalmologist at Nemours, right? So we have an ophthalmologist who will go into the OR and administer these. But again, these are more invasive. Again, this is a site you want to keep as sterile as possible because infectious disease is so likely to occur here in the eyes. So we're going to be mainly focusing just on the topical aspects, but just keep in mind that there are more invasive, more depending on what the actual indication is, what you actually need to be treating here. So looking at this, it's pretty convenient from a treatment standpoint instead of going in with something much more invasive. So that's why we like topical so much. It's relatively safe for the most part. Anyone know like kind of the biggest risk with using topical eye products is? Yeah, infection is the biggest thing. You just need to keep that stuff clean, right? So we'll talk about patient education in just a little bit, but like, spreading around cooties, sharing eye drops between people, like it's no good, right? So that's really the biggest thing to note there. Obviously, compliance is going to be a big concern here as well, because most people, if you're not used to having, contacts or things in your eyes, like people don't really like to, have stuff put into their eyes, right? So like little kids and things like that, they're going to fight you oftentimes. But anyway, we'll get into the details there. Other things to note is that most of the drugs we're administering are going to be given as solutions. So what do you think the dose is when we're giving things as solutions in the eye? Drops. Yeah, via drops, right? So your dose is typically in drops. How about with something that's going to be a little bit more thick and viscous, like an ointment or a gel? What would my dose be in? See, a strip or a ribbon? How would I dose it though? So distance, right? So length would be how I'd actually want to dose that. So there's very few things you would measure or you dose in length. Nitropace is a good one. We talk about nitroglycerin a little bit later on in cardio. But if you ever see erythromycin ointment, you're doing a 1/2 inch ribbon applied to the affected eye, right? Or you're doing a centimeter ribbon, something like that, right? So again, this is kind of an odd or a different sort of dosing that you're going to see with that versus other dosage forms there, right? So what's the benefit of using, say, a gel or an ointment versus something that's going to be less viscous, like a solution? Sticks around for longer. So we talk about that contact time. The more contact time you have, the more time the drug is going to be sticking around, the more time it's going to have to actually have its mechanism of action. The other big thing as well is if the eye is inflamed and irritated, oftentimes having those gels and ointments sticking around for longer can help be kind of soothing, right? And so this is one of these cases, a rare case where even if you don't really suspect a bacterial infection in the eye, oftentimes we'll prescribe ointments anyway, antibiotic ointments, because of some of the characteristics of it. But the biggest thing is just because it's going to help relieve some of that pain and irritation in the eye there. Okay. But again, more absorption is going to allow for means more time in the cul-de-sac sitting there right on the eye. Now, sometimes we can do things like putting in like silicone inserts into the nasolacrimal drain, or we could do, or duct, I should say, or potentially like cauterization of the nasolacrimal duct. Sometimes that will also help you increase the contact time, but that's not done as frequently, obviously. The biggest thing to know, though, is with nasolacrimal drainage, you can see systemic absorption of these drugs. Okay, that means that you can get systemic side effects from these drugs, even though you're just applying them to the eyes. Just like with dermal stuff, you can still see a systemic absorption of dermal products, but a lot of it depends on the drug, a lot of it depends on the concentration, etc. Same thing is going to be applying here. Okay. So anyway, so as I mentioned, the absorption, as far as the kinetics go here, that the time in the cul-de-sac, the time it's going to be in contact with the eye means you're going to be getting better absorption there. But of course, we still think about nasolacrimal drainage as being the main thing that's going to be causing the drug to, cause some systemic absorption there. Now we can change things by changing the formulation, or as I mentioned, maybe blocking off some of that drainage there. So the other big thing with nasolacrimal drainage is it avoids first pass metabolism, right? So what do you think that means as far as the amount of drug actually being absorbed? It's going to be a little bit higher. Yeah, you don't have the benefit of the liver kind of metabolizing that drug, and so you get pretty decent absorption. In fact, for some of the drugs we'll talk about beta blockers specifically, you can see pretty significant worsening of things like CHF if you have a patient who's using it who gets that really good absorption of the drug there. So we'll talk about specific examples when it becomes a problem just a little bit. But again, that's where you see that systemic side effects. And again, when you're looking at the eye, obviously you think of the eye as a very sort of thin membrane, a thick membrane, versus like say the skin. Pretty thin, right? So you still can see some pretty good absorption of things there. Obviously, the surface area doesn't really change because the eye is what it is. But the other big thing we can change is also the concentration of the drug, right? Lipophilicity of the drug we can't change. That will make some things just naturally more easily crossable. But the concentration can be a big thing. Increasing the concentration means you're going to have more absorption of drug typically. Usually after the drug gets systemically absorbed, you're going to find that it's not really going to have any kind of special kinetics at that point. It's going to go wherever the drug would naturally go if I were to take it orally or via IV. But some drugs can actually even like to accumulate directly in the eye. So here's a really example of a really old drug called chloroquine that actually can accumulate, and you see this kind of bullseye lesion here, which is kind of interesting. Again, not usual, but sometimes you can see that occur here. Now the eye can have some limited metabolism that occurs there, but the main thing is once the drug is in the system, it just undergoes normal hepatic and renal metabolism and elimination. So getting into the actual drugs here, obviously a lot of the cause for people coming in to see you either at the ER, the urgent care clinic, or in your family practice clinic, wherever you are, infectious disease of the eye is going to be a big thing you're going to run into, right? Obviously with periocular infections, they can be either kind of preseptal or they can tend to be more involved and be more postseptal, or as we call it, orbital cellulitis. And looking at how we treat these is very dependent on the involvement of the disease, right? Because anytime you're dealing with something that could affect a sense, right? So either your hearing, your sight, your smell, you want to usually take that pretty seriously, right? Because if someone comes back and they say, oh, I can't see anymore because of you, not great, right? So anyway, so one of the things you're going to find is that the more involved the disease is, the more serious it is, you're going to be more relying on systemic therapy, right? So we've already talked about systemic antibiotic therapy. So I'm not really going to be talking about that too much here. I want to talk about mainly the topical products we're going to be seeing used for more of the minor cases, the preseptal sort of infections we're going to see there. Okay, but just know that anything that is going to be leading the patient to maybe having any kind of more involved disease, if they're immunocompromised, if they're under cancer treatment, if they have HIV, things like that, they probably need more systemic therapy, right? How involved the disease is, as I mentioned, can be a big determinant there. Usually I find that's not frequently done. If it's more of like an orbital cellulitis, I see typically just like IV therapy is really the big thing. Because again, by giving it parenterally, you're getting big concentrations anyway. There may be some rare cases where you do that. I'm just not aware of them. Talk to like an ophthalmologist that may know more than that. But again, think about things like, clinical setting, like if they had trauma, right? So again, if they had an injury where they actually had foreign material getting into the eye, that again is going to make you think, let's use more systemic therapy there. So let's focus on the topical stuff. Now, looking at this, typically for the small, mild peripheral infections, this is where we're going to be using our topical antibiotics here. The reason why we like topical stuff is that it limits a lot of the side effects you're going to run into. So one, limited systemic bioavailability of the drugs here. We can get really high local concentrations, which what does that mean for dealing with the bacteria? Yeah, we really don't have to worry about resistance. I can use erythromycin eye ointment all the time, and it's not going to be a problem because we get such high concentrations right there in the eye that it really can't fight off that resistance, right? However, if I were to do that systemically, if I keep driving up the dose, I could overcome resistance, but what's the downside? Toxicity, right? I can't do that, right? The only other thing with ocular applied meds, you typically have to apply pretty frequently, right? So you're thinking like at least twice a day, if not 4, 5, 6 times a day, okay? Especially the more involved it is, the more inflamed the eye is, the more just the kind of the nastier it looks like, the more often you're probably going to want to be dosing the stuff, right? We typically use pretty broad spectrum antibiotics, which I said typically we like to narrow down spectrum whenever possible, but in this case here we can go more broad because again we have very high concentrations. And typically you don't need cultures. You're not going to be culturing these patients because again they're pretty limited infections as far as severity goes. However, if you were worried about something like say a fungal infection in an immunocompromised patient, that's something you may want to consider there, but it's much more on a case-by-case basis. However, when you have something like an infectious conjunctivitis, what is most often the culprit? Usually going to be viral, right? So you're going to find that in a lot of cases you may not be able to adequately distinguish between viral versus bacterial conjunctivitis. In a lot of cases, patients are going to get therapy for bacterial regardless, right? Because again, it's one of those things where there's relatively few downsides, and plus even just applying the antibiotics itself, especially with like ointments and things, are going to be very good from a comfort standpoint. So that's something to note there. But again, it could be allergies, could be chemicals getting into the eyes, could be environmental, all kinds of things like that. So you have to be really careful with trying to delineate what is going to be the actual causative thing here. Now, for instance, they have contact lenses. What do you think about from a bacterial standpoint? Yeah, you always want to think about Pseudomonas. That's one thing that's going to be delineating which antibiotics we're going to use, and so I'll point that out when we get to those drugs there. Okay. And of course, you can have certainly autoimmune conditions, tumors, things like that. But as far as infections go, you still think about skin stuff. You still think about things like Staph aureus and strep, but you can also see things like Neisseria and Haemophilus here. But it's a little bit more of kind of a wide smattering of bugs rather than what you would see with like other things like UTI or like upper respiratory tract infections. But again, our main goal here is try to get rid of that infection if we can, and avoiding kind of long-term complications. So here are the drugs we're going to be using here. Now again, we've already covered the majority of these as far as mechanisms of action, things like that. We'll cover specifically here what kind of side effects you're looking for from a topical standpoint, but again, you're not going to find that you're going to see a lot of systemic issues here, right? So if I give erythromycin eye ointment, typically you think about what drug interactions systemically. Could be QT prolongation, but what else? Yeah, so we worry about absorption, but again, we're not going to the GI tract. You don't have to worry about it. CYP enzyme interactions, right? I don't have to think about that from a topical eye standpoint because it's not getting systemically absorbed. Okay, so again, you end up losing a lot of that. So this is why we like the topical route whenever it's feasible here. Okay, so we'll go over these again. It's not important that you remember specifically which ones are solutions, which ones are ointments. You can look that stuff up. Okay, you can look that up in your Terrascon or your Lexicomp or whatever you're using. So first off, we have the macrolides. As we remember, they are protein synthesis inhibitors used for just a wide variety of bacterial conjunctivitis. Probably erythromycin is going to be the most common one you're going to run into. And when we talk about adverse reactions, again, all of them can cause eye irritation, right? The eye is probably already irritated to begin with, so it's one of those things that, are we just worsening it? Is it the drug formulation? Who knows, right? One thing to note, though, can you use any non-ophthalmic preparations in the eye? No, you should not. However, if I was using like the ear, could I use non-otic preparations in the ear? Absolutely, right? Because which one do you think is a little bit more persnickety about what kind of solutions get instilled into it? The eye, right? Because again, you have to think about tonicity, you think about pH, you think about all of these different things that could lead to irritation of the eye because it is much more sensitive tissue. So because of that, you can never use otic products in the eye, but you can use eye products in the ear. That'll become important when we get into ENT in just a little bit here, okay? But again, all these are going to cause eye irritation. That's just like saying antibiotics cause nausea, vomiting, diarrhea. Like it's just, yeah, that's a given. Okay. Some patients may be hypersensitive, but pretty rare. So as I mentioned, with the erythromycin, it comes as an ointment. So you see here we're instilling ½ inch 2 to 6 times per day, depending on severity. I'm not going to ask you specifically on the dosing of these things. I'm just trying to illustrate how you might see it being used out there in the real world, or if you have to write a prescription on it or something like that. With azithromycin, comes as a solution, so that's going to be a drop there, right? So again, it's going to be something that you can just apply. It's actually kind of interesting with the azithromycin, even though it's a solution you think that would get washed away more easily, it still has a pretty long half-life and will stick around. And so this one you only have to give, say, daily, or twice daily for 2 days, and then just 1 drop daily after that. So it can be nice from a compliance standpoint. Instead of trying to get, if I had a little kid and I was trying to put ointment into his eye 6 times a day, like they're going to be fighting me like crazy, right? Versus if it's just 1-time drop, maybe that's going to be easier from a compliance standpoint. So as I mentioned, erythromycin, that ointment can be nice and kind of soothing on the eye. Even if you don't think it's a bacterial infection, this may be appropriate for some patients. However, with the azithromycin, I would not really be prescribing that unless I really thought it was a true bacterial infection, mainly due to the fact that it's much more expensive than erythromycin ointment. Erythromycin's been around forever. Azithromycin is relatively new compared to that. Okay. Up next, we have Trimethoprim and Polymyxin B. We remember Trimethoprim. How did that work? It's a folic acid antagonist, right? So again, it was usually mixed with a sulfa, right? A sulfamethoxazole, as we saw in Bactrim. Here we're actually mixing with a drug called Polymyxin B. Do I talk about Polymyxin B in the antibiotics? It's something we don't use commonly systemically because it is so nasty from a toxicity standpoint, but we do use it topically all the time. So for instance, when you go to see Neosporin, like you have a cut or a wound or something like that, and you put Neosporin on it, typically it's Bacitracin, which we'll talk about here in a second, Neomycin, which is a type of Aminoglycoside, and then Polymyxin B. We can use these topically because you don't really see a ton of absorption. They're very good at killing bacteria, but they're also really good at hurting us too systemically. But it basically will be able to disrupt the cell membrane and able to kind of lyse that open, basically kind of like puncturing a hole right through it almost. So anyway, so we're going to be seeing here, again, just a different combination. So again, your choice here is mainly going to be dictated by things like the cost, what you have availability to, things like that. So again, usually used for bacterial conjunctivitis, again, adverse reactions, ocular irritation, nothing really new here to know with this one. Okay. Another one we use pretty frequently is sulfacetamide. Again, this one could either come in an ointment or solution. The one thing to note with this, it being a sulfa drug, what do you have to think about? Allergies, right? So if you had a patient who's say allergic to Bactrim, I probably would not want to administer this to them, right? They probably won't get anaphylactic, but they may have a local reaction that's going to just worsen that inflammation there. So again, that's something else to think about. And again, how does this one work? Still a folic acid antagonist, just working on that different step of the pathway there than trimethoprim did. Perfect. So again, watch out for those allergic reactions. Next we have bacitracin. This one is actually going to be inhibiting cell wall synthesis as well. This one you'll maybe see used in surgery sometimes for like a washout, you know, for say after like, you know, I saw one patient, one of my students had a note where they did a washout. It was after a sigmoidectomy, laparoscopic sigmoidectomy, and they did a washout with bacitracin. But again, systemically not a great drug. Topically perfect, right? It's able to kill bacteria very easily. Very good activity there. The washout basically, you're not going to be actually applying the drug into like the systemic circulation, but for instance, if I opened up the abdominal cavity to, you know, resect part of the colon there or something, basically you just kind of infuse the solution into the cavity and then you take it back out. So basically washing out the whole cavity, try to kill any bacteria that are there, but it doesn't stick around, right? You want to get rid of it essentially. Yeah, basically, that's essentially what we're seeing.
Put it on the eyes when they're shutting them closed for surgery.
Yeah, so yeah. Again, yeah, so topically you think about that too. And again, the nice thing there is it's going to be able to, the other thing with ointments is it's good because it'll keep the eye kind of hydrated, right? So again, we'll talk about that in just a few minutes. That's a good point. Anyway, just bacitracin is another one you may use. Again, nothing to really distinguish it from any of the others we've talked about thus far. Okay. Yes, sir.
I'm just kind of so that's used for washout?
So not the eye ointment, but bacitracin in a different form, right? Yeah, sorry. I mean, sometimes I go on tangents, you know this. But yeah, so bacitracin is just something, just a different way you may see it. And if you go into surgery, you may ask them about it. Like, hey, have you ever seen like a bacitracin washout? Oh yeah, we do that for some wounds all the time. But again, it's just a very kind of quick sort of thing, right? But anyway, so this is the one where we're starting to see a little bit of difference here with fluoroquinolones. Now, typically we don't like to overuse fluoroquinolones due to resistance issues, and the same is going to be happening here. The nice benefit is that a lot of other drugs we've already talked about today do not cover Pseudomonas. The fluoroquinolones, though, we do know cover Pseudomonas, right? And so again, by inhibiting that DNA gyrase, they're going to have better activity there. This is going to be good for patients, especially with corneal ulcers, especially when you're starting to think about Pseudomonas as being playing a role here. So again, if I set on a test, patient comes in, you know, a contact lens wearer, they have a corneal ulcer, you diagnose, you're worried about Pseudomonas, what's going to be a good drug to cover this? And I'll have, you know, say bacitracin, erythromycin, something else, and then, you know, ofloxacin. You'd be able to pick out that ofloxacin is going to be the best option there due to pseudomonal coverage, right? Other thing to note, sometimes you'll see some white precipitate, especially with ciprofloxacin. You can see that with the drug basically kind of the carrier vehicle kind of evaporating off and leaving some of that drug behind. So again, that crystalline powder is not necessarily just more discharge, it's just more due to the drug itself. And then occasionally you can have an unpleasant taste. Why do you think that is? Yeah, the nasolacrimal drainage is where you're going to see that. So again, you can see a little bit of nasty taste in the mouth. Okay, so these are very effective, and again, prefer for those corneal ulcers or if you have Pseudomonas or something. Very expensive though, right? And then we also worry about resistance being a problem. So I would not use this as my go-to for just typical regular old bacterial conjunctivitis, right? Something like erythromycin is going to be much better for that. And again, looking at, I'm not going to do specific on dosing, but typically the more severe the disease is, typically the more frequent you're going to be doing this, right? And again, what do you do with your contact lenses when you have an infection like this? Toss them out, right? Do not want to reuse them because, again, you may see reinfection occurring there, okay? Okay. The aminoglycoside, oh, yes, sir. Yep. Yeah, essentially, yeah. They, because again, you know, we saw it with like Cipro, you may have like plus or minus coverage on Pseudomonas depending on the strain you run into. Again, we're getting very high concentrations right on the eye, so you can overcome that pretty easily. Yes, sir.
Does moxifloxacin have Pseudomonas coverage? Because in our slide it said negative Pseudomonas.
So this is a case where again you can use those high concentrations to overcome that, right? So again, it's a totally different ball game when you're using topical therapy like that. So you can use Avalox for that for sure. Yep. Okay. Anyway, Next we have the aminoglycosides. Gentamicin is probably the biggest one I see being used most commonly out of this group here. Honestly, the biggest place you're going to see this probably being used is in the delivery suites. They will apply this to a baby's eyes right after being born, especially coming through the vaginal canal, because you worry about picking up any bacteria from the birth canal from the mom. And so again, I remember when my baby was first born. Of course, you stop being a medical person as soon as you become a patient or someone close to you becomes a patient, right? And so my daughter Lily was born, and I was like, oh my gosh, what's wrong with her eyes? She has like this goopy, gross looking eyes. And, like, that's just the gentamicin. I was like, oh right, that's right. I forgot you do that. Usually they just get a one-time dose just to try to make sure there's any kind of cooties that get spread from mom to the baby, and then they're kind of done after that. That's good because you actually can see some problems with the aminoglycosides. These are not really preferred in a lot of cases, mainly due to the fact that they can cause ulceration themselves, right? And again, you don't typically want to cause more problems for your patient with the drugs you're using. And some patients may have kind of a reactive sort of a reaction to it over time. It's usually over several days use. So again, limited use case for when you're using the aminoglycosides here. Okay, going on to looking at some antiviral options here. Now, typically when you're thinking about viral conjunctivitis, do we typically have any specific drugs for that? Not really, because you typically think of like a run-of-the-mill, like, adenoviruses, rhinoviruses, things like that. So you don't typically see use for that. However, when it becomes more serious, when you have things like a herpes zoster infection, you see anything where like a cytomegalovirus, right? These are typically going to be more in immunocompromised individuals. This is where you're going to be running into problems, and you may need antiviral therapy here. Now, typically you're going to find that with a lot of these patients with more, especially with immunocompromised ones, you need more systemic therapy because it may start out in the eye, but chances are it's probably elsewhere as well, and you want to be able to treat that effectively. But for the most part, if it's just a typical run-of-the-mill viral conjunctivitis, you don't really need to do much with it. Maybe some eye drops, maybe something to help soothe the eye, but beyond that, nothing specific as far as therapy goes. So just to show you, and again, we'll cover some of the more systemic antivirals in another section. These would be things like acyclovir we'd be administering systemically. The two I do want to point out here are the ones that we actually have ocular products for. This includes Trifluridine, and then we're also going to have Ganciclovir. Okay, so we'll talk about these specific here in just a second. So Trifluridine, a lot of the way that the antivirals work are by actually getting incorporated into the viral DNA, and then they basically stop further propagation of that DNA strand, right? So they get incorporated and they act as a chain terminator, where basically the virus cannot continue to replicate due to the fact that the DNA is being inhibited at that point, okay? So you see a lot of them work that way, and Trifluridine is no exception to that, and basically will get incorporated in place of thymidine here. Basically, we'd use it for herpes simplex virus infection of the eye. And just note that here, the kind of unique side effect with this one, you end up seeing a punctate keratopathy that can happen here. So again, kind of unique side effects is why I kind of point those things out. But again, I may ask on a question, patient comes in, you're worried about herpes simplex, conjunctivitis, which drug would be effective for this? You're going to put 3 antibiotics, put some antifungal, and then I'll put Trifluridine. You need to be able to pick out which ones are the antivirals, which ones are the antifungals, etc. Okay. The other one is Ganciclovir. This is frequently used for cytomegalovirus, which is something that normal healthy individuals do not normally get, but those, especially with like HIV/AIDS, active cancer treatment, may be more at risk for. And so they end up developing these CMV retinitis. Can be pretty damaging to the eye over time. And so sometimes what we'll actually do is this actual an insert. We'll actually do an implant of Ganciclovir actually into the globe of the eye and actually allow for have slow release of drug over time. And that's going to be better for actually managing that. Because again, what's the problem with an immunocompromised individual trying to fight an infection? They can't do it, right? So again, we have to give them that extra help, and so by keeping the drug around for a long time can sometimes help with that, right? That's where Ganciclovir can come into play. Yeah, you would have to take it out at some point because again, there's some foreign material there. I'm not sure if it's specifically plastics or something like that, but yeah, you'd have to take that out at some point. Yeah. As far as antifungals go, there's really only one agent we're going to be using topically, and it's going to be natamycin. And so this is going to be working by basically disrupting the fungal cell wall. By breaking that down, it works very similar to kind of other cell-active antibiotics we already saw. So you kind of lyse out the fungal contents there. Now, again, who might be at risk for a fungal eye infection? Typically immunocompromised individuals, but other people could be things like, if you have trauma. So if you were to have, fungal exposure after a car accident or a motorcycle accident or something like that. Contact lens wearers tend to be at a bigger risk for this as well. So again, sorry if you wear contacts, but just a bigger risk. As I mentioned, immunosuppression is the other big thing as well. So, as I mentioned, increase that permeability in the cell wall. And again, don't get hung up on which specific fungi it works on. Just know that it works against fungus in general. This is probably not going to be at the top of your differential for all these patients coming in for conjunctivitis. But if you have that history of preceding trauma or contacts or immunosuppression, these are things you want to be kind of thinking about, right? Okay, so again, whenever you're dealing with patients with eye complaints, you want to check a visual acuity before and after. You're looking for changes, right? You want to make sure things are not getting worse. You want to see things are going to be getting better here, right? So it's always good to make sure you're documenting the visual acuities when they occurred. Make sure you're documenting allergies and things like that. And obviously, the thing to always recommend is if your vision gets worse, come back, right? Or go to the ER, right? It's the other big thing as well. If it's over the weekend, you don't want to be like, well, you told me to come back to you and it happened over the weekend and now I can't see out of my left eye. Like, it's no good, right? So always have that caveat. If things get worse, go to the ER, right? It's always going to be your out. How do you actually administer medications? I cannot stress enough. The biggest thing to do first is wash your hands. A lot of people will avoid this, right? So just in general, just wash your hands, okay? People need to do it more often than not. Again, avoid touching the dropper to anything else. Because you need to keep that as sterile as possible, because again, the eye is sort of a at-risk site for developing these infections in the first place. Basically, you're going to have them tilt the head back, and then you're going to have them pull down the lower eyelid, and you form a nice little pocket there. And that's basically we're going to be aiming for shooting the drug in there, right? Whether it be a ointment, whether it be the solution, whatever the case may be, you can form that little pocket. Using the other hand, you're going to get the dropper as close as possible without actually touching the eye and administer the drops, how many ever you need to do based on the prescription. And after that, what you're going to find is that you want to make sure they will close the eye and then apply pressure here in the corner. Yes, sir. So we'll talk about that in a second. So yeah, so just focus on solutions now, but yeah, we'll get to that in a second. And then you want to make sure they put their finger here at the bridge of the nose. Why do we do that? Yeah, that will help to keep the drug in place for longer by preventing that nasolacrimal drainage. Okay, so do that for 2 to 3 minutes or so. Now, if I have to apply 2 drops, like say for instance, I have a glaucoma patient, I'm applying 2 different drops, how long should I wait between? Like immediately? Do I have to wait at all? Give it a couple minutes, right? Because again, you don't want the first drug to wash out the second drug to wash out the first one. So you want to give it a little bit of time. A couple minutes is fine. That's why we like combo products as much as we can, and we'll look at those in just a few minutes here. Okay, that's the biggest thing. And then wash off any excess, and then you're good to go, right? They'll have to kind of keep off any precipitate or anything like that. Now, as I mentioned, ointments tend to be much better for children or patients with poor compliance. Even if the drug is just on the eyelashes, you're still going to get some contact there, and you're going to find that you can still get some local action, which will be good. The only other drawback to the ointments, though, is you're going to find that for about 20 minutes or so, you could have some blurred vision. So if someone has got to hop in their car and go somewhere right away, it may not be the best option for them in those cases. Okay. Now, as I mentioned, with the gels and the ointments, you can kind of squeeze the ribbon out of the medication, but try not to actually make direct contact. Again, it's kind of like maybe you can have some kind of like twisting motion to kind of to twist it off a little bit. That can help out with that. It's a little bit more difficult, but it can happen. With that one though, because it's much more viscous, you don't really have to worry about covering up the lacrimal duct. That's going to be no issue there, right? As far as I mentioned with contact lenses, just get rid of them. Typically, we can resume using contact lenses about 24 hours after you get rid of, after the inflammation's kind of gone away. That way you kind of make sure that there's been no inflammation, no discharge, things are not coming back. That 24 hours is good to kind of give them a little bit of rest time, and then they can get it back in. Also, get rid of eye makeup, unfortunately. Sorry if you use the really nice stuff. You know, if you go to Ulta or something, like I recommend getting rid of it. Unfortunate, but it is what it is, right? Again, don't share eye drops. Don't share makeup if you can, because again, you just spread the goodies around. Okay, so moving on, talking about histamine and allergic response. Now we're going to be looking more at allergic conjunctivitis versus strictly an infectious cause here. Now again, when you see allergies occurring, the big players here are going to be things like mast cells, and also your basophils are going to be playing a role here. You know, IgE is going to be one of the main immune globulins that's going to be involved with this, right? As far as the inflammatory cytokines are being released here, one of the big players we're going to be focusing on is going to be histamine. Right, we're going to see this as well when we get into the ENT section next. The histamine is the biggest player here and the biggest thing we can affect with drugs. Okay. Now, when you see this reaction occurring, you're going to see a lot of vasodilation. That's where the eyes get very injected. You're going to be seeing a lot of swelling due to having increased gap junctions in those the vascular endothelium. You're going to have fluid leaking out. You know, the itching is going to be occurring there due to the histamine. So most of the drugs we're focusing on are going to be trying to kind of resolve these issues here. So as I mentioned, H1 receptor antagonists or H1 antagonists, we're going to be using these to try to decrease that capillary dilation. That will decrease the itch and then decrease the swelling you're going to see there. Okay. Now, the antihistamines we have available from an ocular standpoint, and again, when I say MCS, that just means mast cell stabilizing. What do you think that means? It prevents the degranulation of the mast cell. So again, some of these have some mast cell stabilizing properties. We're going to look at a few that are specifically mast cell stabilizers in just a second, but these are mainly working as antihistamines. Now, the thing to note when you're looking at the difference between an antihistamine and a mast cell stabilizer, which one do you think works on an acute, already happening sort of allergic conjunctivitis? Antihistamines, right? Because you've already released the histamine, it's already causing its effects here. Mast cell stabilizers, though, how effective are they going to be once the mast cells have already been destabilized? Not very good, right? So again, those are going to be better from working on long-term management. You have to give those consistently. So if you have someone who knows at a certain season they're just going to have their allergies going crazy, or if they're around certain pets or things like that, they're going to cause their eyes to go crazy. They need to be using those beforehand, right? Because once the mast cells destabilize, those are not going to be good anymore. You need to have an antihistamine at that point, okay? So the few we have things like azelastine, imidastine, apinastine, ketotifen, and then olopatadine. Probably these two are the ones I see most frequently, the ketotifen and the olopatadine. Zatador is available over the counter, so again, that's going to be something you see a lot of patients self-treating with anyway. And again, what's always a caveat when they're self-treating? Yeah, don't do it forever, right? Because again, they could actually have a bacterial conjunctivitis that they're trying to treat through just the symptoms of and not realize it. Okay, so it's one of the things to know.
So these all have MCS?
Some of them do, but the primary mechanism of their action is going to be antihistamine, right? So just know them as an antihistamine. If it comes up on a test question, which one of these are an antihistamine, ocular antihistamine? That's what I want to ask them for, right? So dosing typically 1 to 2 times a day. The onset's much quicker for the antihistamines. You'll see with the mast cell stabilizers, as I mentioned, due to the mechanisms there, how they're working. Typically for these, you want to give them a good full 2 weeks before you really say whether these are going to be fully effective or not for your patient. Just depends. And again, no issues here as far as adverse effects. One thing you will note is some increased ocular dryness. A lot of that kind of makes sense though, right? Because again, you're going to be causing constriction of those vessels, less water's getting through, so you could see some dryness there as a result of that. Okay, no big drug interactions, and we typically prefer these over the mast cell stabilizers. But not everyone can tolerate those, so in some cases we have to go and switch over and use those, as the case may be. But again, working by basically preventing the actual allergic reaction from occurring in the first place by keeping those mast cells from degranulating, right? So limit release of things like histamine and tryptase, etc. It will help to limit some of the other white cell activity there. Okay. The biggest one in this group include things like cromolyn, lidoxamide, and then netocromyl. Again, I see these being used less frequently than the antihistamines, but it's good to know as an alternative what you could use if they had an intolerability. They could not use antihistamine. This would be a good backup. So if I had a test question, I said a patient, experiencing allergic conjunctivitis, tried using Pataday or Patanol, and they realized that, the ocular dryness was just too much for them, what would be a good alternative? And you could say, okay, well, netocromyl might be a good one, right? And again, you need to give them at least 2 weeks before you really see full efficacy, but they're not good for acute symptoms, right? So, for instance, I just went up to go visit my brother up in Ohio. He has a dog. I have bad reactions to dogs, so I was around the dog. Of course, all of a sudden start wheezing, and then my eyes start getting all red and itchy. That would not be a good case for mast cell stabilizer. I need to use that beforehand, right? And again, a lot of these end up requiring pretty frequent dosing. So if you had to do that all season 4 times a day, it's kind of a bummer. So compliance is not going to be great from that standpoint, okay? But it could be good as an alternative. Now, getting into some more over-the-counter products that are going to be available that a lot of patients are going to be using. We're getting into vasoconstrictors and antihistamines, okay? So the vasoconstrictor makes sense. It's actually going to be working on the alpha receptors that cause vasoconstriction of the vessels in the eye, and it's going to decrease that redness you're going to see with that. Now, the ones we see here are going to include things like tetrahydrozoline or Opticlear, you have nefazoline and phenyramine. Again, you're going to find there's a lot of different over-the-counter brand names for these. So again, you might see Visine, you might see, there's all kinds of different ones out there once they become over-the-counter. But the thing here with phenyramine, this is actually an antihistamine mixed with vasoconstrictor. So actually by combining those two, you get a little bit of extra kind of bang for your buck, some extra synergy you can see with that. Okay. Now, these are good for short-term use. You're going to find you do not want to use these for too long, because the problem is you remember when you start to activate, or say, for instance, in this case, we're activating, we're activating those alpha receptors, right? We're causing vasoconstriction. What happens to the receptors over time if you're constantly hitting them? They're going to downregulate, right? So then when you take the drug away, what happens? you get rebound hyperemia, right? So you're going to see that rebound hyperemia, and that can be even worse symptoms they had when you're first trying to treat those allergic symptoms. Okay, so because of that, you do not want to use these more than 2 weeks because the patient basically becomes dependent on having that vasoconstriction around. They can taper off their dose over time. May take a week or two, but again, just let them know that's something you want to really limit how long you use this for. This is going to be a very important counseling point for a nasal product we're going to talk about in the next section. Not necessarily. It's just the vessels are going to be basically going to be wide open, right? So because you have less alpha receptors there, right, because they've downregulated, and you take away the drug that was causing them to constrict in the first place, you can be releasing norepi and epi to try to constrict those vessels, but the receptors just aren't there, right? The numbers have diminished, so you're going to find that they dilate. So if anything, it would be not to say hypertension, as the case may be, if you would see that more of the actual the constrictors, but the vessels will go wide open. You see more of that edema, you see more of that that swelling, you see all that redness that comes along with that. Yeah, just because a lot of blood flow is coming into the eyes all at once. So anyway, but yeah, that'll be important. We look at a drug called Afrin in just a little bit here. Okay. Now, typically, again, if they don't see any improvement over the course of a couple of days, have them come in and get checked out, because again, it could be something more serious they're dealing with than just something, it could be more bacterial or something like that. Now moving into the NSAIDs, now these, again, those products were all over the counter, the vasoconstrictors there, but as far as NSAIDs go, these are going to be prescription-only products, and these are going to be more limited as to when you're going to be using these. And we remember, how do NSAIDs work? Yeah, they're stopping prostaglandin synthesis by basically working against an enzyme called cyclooxygenase, or COX, right? So you're going to have COX-1, COX-2. For our purposes, just know that they are going to be inhibiting inflammation. We're going to talk a little bit more about NSAIDs in the next section as well, but here we're going to be focusing on the ocular ones, right? And so a couple ones we have here are going to include bromfenac. We have diclofenac. Diclofenac is actually a very good, another topical one you can see used for topical pain relief. We'll talk about that more like in ortho section later on. We have flurbiprofen and then ketorolac. A lot of people say ketorolac. It doesn't really matter which one you say it. But those are going to be the ocular products we have available here. The main places these are going to be used is if you had, say, allergic conjunctivitis that was not responding well to antihistamines. This may be a good backup. More often than not, they're going to be seeing this in the post-operative setting after ocular surgery. This helps decrease a lot of that inflammation that will occur in the post-op period. Okay, so again, very limited use. We don't like this as much because of the side effects you see with this. You can develop keratitis. You have increases in intraocular pressure, and then you see further irritation there. So again, not used as commonly, but maybe used as a backup. And again, from the family practice sort of standpoint, probably not something you're going to be using a lot. But if you ever see a patient on it, you at least want to be familiar with it and know what it's actually doing. We also have some glucocorticoids, right? And these are going to be even stronger as from an anti-inflammatory sort of standpoint. But however, we're also going to be seeing that these are going to have the most side effects associated with them as well. Okay. Again, we can see these for very severe ocular allergies. Again, not used commonly for that. And then usually going to be like after ocular surgery and whatnot. Again, we remember that corticosteroids do what to wound healing? Typically decreases your eye, so in some cases you won't be even kind of limited in using it for those post-operative periods as well. You need to be very judicious. Probably the ophthalmologist is going to be the one really recommending these for the most part, right? Some cases we'll actually do intraocular steroids, like some of our docs will actually do that for certain cases, like really severe uveitis and things like that. So it just depends on the setting you're in. But again, these are going to be working basically from the nuclear transcription down as far as inhibiting inflammation by decreasing transcription factors, things like that. So you're going to be seeing less, recruitment of white blood cells to the areas of inflammation, less of those cytokines being made. Kind of work from the head of the pyramid down.
This cause thinning of the eye, like the skin.
You don't necessarily see thinning of the eye from that respect. You do see a lot of other issues though. So for instance, you can see things like cataract formation. You can see things like increases in intraocular pressure. It's a lot more with patients, especially with the history of glaucoma. But if there is corneal thinning or something like that, I'm not aware of it. That'd be kind of interesting to see. You can get ulcers, so maybe in that case you could be, I guess you could be seeing as a case for that. But typically, again, we like to limit how long we're going to be using these for. Typically less than 2 weeks or so. Okay. Again, you do worry about things like having. This isn't one of those ones I really think about a lot of systemic absorption of, causing a lot of problems from like an adrenal standpoint. But just know we usually like to limit use because it can cause a lot of these issues like cataracts and whatnot. The ones we have available, we have things like dexamethasone and prednisolone. You see these being used all the time for things like asthma and other allergic conditions. But some of the newer ones that you may not have seen before include this difluprednate. We have fluoromethalone, loteprednol, and then rimelexone. The ones that have stars next to, these are considered to be soft steroids, and these are ones that actually have less intraocular pressure increasing effects. So that may be better for a patient who has a history of glaucoma, things like that. It'd be a good option for them in those cases there. Okay, so if you have dry eyes, it's a common complaint for a lot of patients there. You can see these occurring due to all sorts of reasons. It could be chemical burns, could be anything kind of alters the tear composition, ocular surface, anything can cause dry eyes. Certainly lots of allergic conditions as well can do this, or autoimmune conditions. What is one of the things I mentioned with using Accutane? Remember how it was causing inhibited vitamin A utilization? Cause dry skin, also dry eyes is one of the big ones right there. So you may see this is something you may run into from patients with a derm standpoint. But typically we like to treat whatever the underlying cause is, right? So again, if it's something where the Accutane is causing really severe ocular dryness, really wasn't working for them, it would be something I'd say, well, just try something else, right? If possible. In some cases, we can do things like physical interventions, as I mentioned, either plugs or putting like cauterization of the nasolacrimal drain can be good to keep the tears you're producing around for longer. But most often, we'll end up doing things like substitutes, right? So we can either do things like, hypoisotonic solutions that contain electrolytes. So if you ever see like a balanced salt solution, that's usually an eye drop we'll use very frequently as a tear replacement. A lot of them will have things like surfactants and thickeners. All of that will help to keep the drops around for longer. So that way they can kind of help to provide that nice kind of hydrating effect to the eye for longer than a simple normal tear might in those cases. Okay. So some of the agents you might see out there include things like that BSS I mentioned, carboxymethylcellulose, polyvinyl alcohol. All those are really good agents to be used there. Now you mentioned before surgery, patients getting gentamicin in the eyes, kind of covering up the eyes when they're being intubated and sedated and all of that. Now that's something we'll frequently think about with patients who are in the ICU, who are going to be sedated for a while, who are on the ventilator, things like that. We have to think about ocular care, right? Because they may not be blinking normally, they may not be producing tears, and so again, we'll put either some kind of tear replacement, or maybe use an ointment or something like that to make sure you keep the eyes hydrated. Otherwise, it may develop corneal ulcerations and things like that if we're not keeping the eye, kind of managed there. But another thing we could potentially use is an immunomodulator. This is actually really good for patients who have an autoimmune condition causing their dry eyes. And so basically this is going to be working to decrease inflammation via a very specific route, mainly by inhibiting the release of interleukin-2. And so this is a drug called cyclosporin or Restasis. This is actually the same drug you may see in transplant patients. It's immunosuppressant you may use to help prevent patients from rejecting transplanted organs and things like that. Basically, this helps to increase tear production for those patients. Only problem with it is it actually has a lot of ocular burning associated with it. So it's like, okay, well, my eyes are already kind of burning from the dryness in the first place. Now you're kind of worsening that. But in general, by having that increased tear production can kind of overall help their symptoms for the most part. Again, maybe used for more kind of refractory dry eye symptoms normal tear replacements aren't working for. For the weekend. All right, any questions from the first half? All right, so let's move on. We're going to talk about glaucoma here. What is glaucoma? Increased intraocular pressure. Why is that bad? Yeah, all that pressure on the optic nerve is no good, right? It can cause damage over time, loss of vision. So that's not great. You're going to find that there's both an open and a closed angle glaucoma. Closed angle glaucoma is much more kind of an acutely painful, sort of like possible surgical sort of issue. We're going to focus on the open angle glaucoma. This is more the chronic sort of medical condition that drugs are really going to be focused on here. Okay. Now, the two main ways we're going to be focusing on this, again, what causes that pressure in the eye? It's all the fluid that's there in the globe itself. So what we're going to be focusing on is either trying to decrease the production of that fluid, the aqueous humor, or trying to increase the outflow of it. So that way it can be reabsorbed and decrease that pressure there. So we're going to find drugs that work on both of those pathways. Okay. Normal intraocular pressure, usually around 10 to 21 millimeters of mercury. Once you start getting above that, that increased pressure over time can lead to visual field loss and potential blindness there. But as I mentioned, we're going to focus on open angle glaucoma. If you can see here, the closed angle, you can see that's much more of a, acute, big of an issue. Like that pressure increase is pretty sudden, pretty dramatic. That's why it's so painful versus open angle glaucoma. It's a chronic condition. You may never feel it, right? It's one of those things you just may not know about for a while. That's why it's important for especially older individuals, or if they have a history, to go ahead and have tonometry done and figure out, what their pressures actually are. But looking at this, we're trying to prevent that kind of chronic damage, and so we're either going to be looking at things where, and again, that fluid, typically we're seeing it produced in the ciliary body. We're trying to get that to go out through this flow, where it can be reabsorbed through things like, the trabecular meshwork, can be reabsorbed through the canal of Schlemm and all of that fun stuff. So again, we're focusing on both of those. If we have to combine drugs together to get synergism there, we're going to be focused on drugs that do one and the other, right? So again, just like we would see with antibiotics, when you want synergy there, you want drugs working on two different mechanisms. Same thing's going to apply here. We want drugs with two different mechanisms to try to get more bang for our buck. So just a list you can refer back to as far as increasing aqueous outflow. The prostaglandins are going to be our first line choice from this standpoint. We're going to also see there's alpha adrenergic agonists, and there's going to be some cholinergic agonists here. And then for decreasing aqueous production, we're going to see that also our alpha adrenergic agonists pop up here as well. So you may think, oh, that's already doing dual mechanisms. That might be the best one to go with. We'll find it's not. We'll have beta blockers, which are going to be very prominent in talking about cardiology a little bit later on. And then finally, the carbonic anhydrase inhibitors. Okay? Yes, ma'am.
How do you get how prostaglandins would be treated?
It's a great question. We're about to talk about it right now, right? Perfect. No, it's okay. No, I just kind of list that slide out just so you can kind of reference back to it. When you're thinking about which drugs do what, you can go back and reference that. But thank you for that segue. We're moving right into it. Perfect. So anyway, so again, these are going to be an analog of other prostaglandins, namely PGF2. And so we don't know the full mechanism by why it works, but we do know that it does increase that aqueous outflow. Basically, we think there may be some alterations of the ciliary muscle, maybe changing some of the contractions there, and by loosening it up, you may be able to allow more flow out to the trabecular meshwork cells. So again, sometimes we just don't know really how they work. This is kind of our running theory for now. Now, the drugs that fit into this category are going to be latanoprost, we have travoprost, bimatoprost, and then tafloprost. Okay, so again, easy to figure out the prostaglandins, they all have that right there in the name, right? Now again, looking at the side effects here, you can see some conjunctival hyperemia. Again, that's just known side effect of the drug there. Some irritation, as I mentioned, pretty ubiquitous amongst all ocular products. And then changes in eyelash length and iris colors. Now, you see where the test question came from. It would have been like, had you had this lecture, you would have gotten that right, no problem. But the big benefit here, the reason why we like this from a first-line standpoint is the fact that it has very limited systemic side effects, okay? Because again, typically patients with glaucoma are going to be a little bit older. They have a lot of comorbid conditions. We're going to see some issues with some of the other drugs here in just a few minutes that are going to affect that, okay? So looking at this, you have a patient who's maybe only has glaucoma and say in one eye. You can see here they were treated with a prostaglandin just in this eye versus their left eye, which was unaffected. So you notice that darkening of the iris there, right? So if you have nice, pretty blue eyes, maybe you don't want to have that color change. Maybe that's something you're not really looking forward to, right? And again, just in the sign that, sometimes you can try drugs in just one eye just to see how the patient is going to tolerate. That is something, tactic you can try there. But other things to note here as well is, again, kind of a beneficial side effect looking at the eyelash length before and after. So this is Latisse. There's an example where bimatoprost was a glaucoma drug first and then got marketed as a sort of an aesthetic product afterwards, right? They saw that side effect and they say, hey, this is pretty good. Let's try using this. Now, I have had students ask before, well, with Latisse, you're just applying with like almost like a mascara brush, or I don't know actually, what is it? A spoolie? Is that what they're called? I don't know, some sort of eyelash brush. Let's say that. I'm betraying my lack of knowledge about makeup application. I don't venture to that side of YouTube frequently. I'm not good with like smoky eyes or anything like that. But anyway, point being, the brush to use, I said, well, there should be limited contact, right? Because with glaucoma meds, you're actually applying the drops directly into the eye versus using it just on the eyelashes itself. There still can be some contact. So the risk is probably lower with something like Latisse as far as changing the iris color, but it is still a concern, right? It's something I would not tell a patient, oh, this will never happen, because when it does happen, they'll come back and they'll say, well, you told me it would never happen, right? Yes, ma'am. It can be, yeah. So especially with something like this, where this lady has a very, very darkening, very dark discoloration there, I would probably venture to say that's not going to change, right? And it has to do with the melanocyte kind of being upregulated or being overactive in those cases. That's where you see that discoloration that occurs there. Do you have a question too? Yeah, so depending on the duration, depending on how long they've been using it for, it could be partially reversible, but in some cases it's going to be irreversible, right? So just something to note there. So again, that's a conversation to have with your patient. If they say, hey, this can happen, and they're like, I really don't want to change the color of my eyes, right? But the older you get, maybe you're not really worried about hitting the dating scene anymore. Maybe you don't really care so much, right? Or if they already have brown eyes to begin with, you're probably in the clear there. You may see a little bit of darkening, but it may not make that much big of a difference there. Of course, I had some students who are like, well, brown eyes are good too, and I was like, I agree. My wife has brown eyes. She uses Latisse. That is what it is, So, but again, it's a conversation you have to have with the patient there. Okay. Again, once daily dosing, that's the other big thing from a compliance standpoint. If you actually use it more than that, you actually end up seeing a blunting of the lowering effects, and you can actually raise the intraocular pressure back up further than that. So this is one of those things where more drug does not equate to better, as the case may be. Okay, so the prostaglandin is very well tolerated. Really, just the eye color change is really the biggest thing you're going to be concerned about from a side effect standpoint. Now, the second line agents, and some may argue this may be more of a first line, would be the beta blockers. Okay, so beta blockers, anyone know what those do? Block beta receptors, absolutely. So they're blocking beta adrenergic receptors, and so what this is thought to do is trying to decrease aqueous humor production there in the eye itself by basically preventing things like epinephrine and norepinephrine from interacting with those beta receptors. You can decrease things like cyclic AMP. If everyone remembers that from Intro to Pharm, right? Secondary messenger systems. Yeah, so by decreasing production of that, you have less aqueous humor being produced there, okay? Now, looking at this, we're going to have two big delineations of beta blockers here. We have beta 1 selective. This example is betaxolol is one we have here, and then you're going to have non-selective agents, okay? Because primarily, what are the different types of beta receptors we have? Beta 1, beta 2. There's also beta 3, but clinically we're not worried about that one, right? So there's beta 1 and beta 2. We have non-selective beta blockers, and those we can presume are going to be interacting with both beta 1 and beta 2 in those cases. So why do we care? Why do we want a selective beta blocker versus non-selective? We don't want side effects from the beta 2 effects. We're going to see that in just a second here, so we're going to talk about that. Okay. Now, the non-selective agents tend to be more efficacious, but the side effects are going to be more pronounced there. Okay. Now, they're more efficacious because there are a higher propensity to have beta 2 receptors in the eye, but we're going to find that they will have certain side effects associated with them, right? And if you notice, how can you tell a beta blocker? Typically, will end with an olol at the end of the name there. So for the non-selective, you have cardiolol, timolol, and then levobunolol. Okay. So the side effects we worry about, and again, where do you primarily think about beta 1 receptors in the body? The heart, right? What does beta 1 receptors do in the heart? Increase heart rate, increases contractility, right? So when we block that, what do you expect to see? Decrease in heart rate, so you see bradycardia, and then decrease in contractility, which is not good for someone who maybe has poor left ventricular function, right? So namely CHF patients you're worried about. And again, this is where you worry about the systemic side effects. This is probably the biggest ones we're going to see, where you can have that nasolacrimal drainage leading to systemic absorption. And again, some of your CHF patients can be just teetering on a line there, where just a little bit of decrease in function from the beta receptors can knock them over the edge and can induce an exacerbation. So you have to be careful with that. So other things to note here as well is this increase in airway resistance. So beta 2 receptors, where do you primarily think about those in the body? On the lungs, right? So again, if I have someone who has airway, reactive airway disease, they have asthma, COPD, and they're really reliant on those beta 2 receptors to keep that bronchial smooth muscle relaxed, and I block those, what can I see? Smooth muscle constriction, right? So by causing that, you can actually induce asthma attacks in those patients. So someone with asthma, you want to choose a beta 1 selective drug.
Do these also work like ED, like the beta blockers in our?
How do you mean?
Like, well, where I used to work, we couldn't give beta blockers to any young guy because they were called ED. We were worried about them.
Oh, all right, yeah. So I couldn't tell if you're talking about the emergency department or erectile dysfunction. Whenever I got into pharmacy and emergency medicine, my cousins are all pretty immature, and they're like, I was in ED the other day. Oh, you were in the erectile dysfunction? Ho ho ho. Okay. 10 years later, still not funny, but. Yes, so that is a concern for sure. Where anytime and we'll talk about this more in the blood pressure, sort of the hypertension realm. We talk about those a little bit later in cardiology. But that is a concern. There's erectile dysfunction issues. Probably not so much. But again, you think about the patients you're dealing with, right? These are typically older patients. They may not be. They may have erectile dysfunction for a host of other reasons. So not commonly seen with this one. But the cardiac stuff is the main thing we're really thinking about from that standpoint, right? So if I ask you what's going to be a better drug for a patient with a history of asthma from a beta blocker standpoint, you're going to say a beta 1 selective agent like betaxolol. Okay, we'll cover this much more when we get to cardiology a little bit later on. So I mentioned beta 1 primarily in the heart, beta 2 primarily in the lungs. Again, be careful which ones you're going to be selecting for your patients there. Okay. Now remember, selectivity is all going to be relative. If I drive up the dose of a drug high enough, I can lose that selectivity. But just know for our purposes, betaxolol is a good beta 1 selective agent. The others are going to be non-selective. They will interact with beta 1 and 2. Bless you. So up next, we have our alpha adrenergic agonists. These are actually going to be alpha 2 agonists. And these are actually kind of similar to the ocular vasoconstrictors we saw before, like the tetrahydrozoline and things like that. They have similar mechanisms, but basically what this is doing is working on alpha 2 receptors versus alpha 1. We say alpha 1 receptors typically do what to blood vessels? that vasoconstrict, right? Alpha 2, on the other hand, are going to be what we call autoreceptors. So these are going to be working presynaptically in a lot of cases to decrease outflow of norepinephrine and epinephrine, right? So again, when we see drugs like these being used systemically, we're going to see them being good for decreasing things like heart rate and blood pressure. Well, these are going to be working in the eye directly to actually help to increase both the outflow from a presynaptic sort of standpoint, and then we'll be working postsynaptically to actually cause decreased aqueous humor production. Okay, so again, kind of working with the dual mechanism there. And the two we have are going to include aproclonidine and brimonidine. Now, the nice thing about these is they tend to be a little bit more charged at a physiologic pH, which means they cannot cross the blood-brain barrier. You're going to find that when this does occur, you can see things like apnea and sedation being a big side effect, which is why you do not want to use these in kids, say, less than 2 years of age. Okay, that will cross the blood-brain barrier for them, because it's a little less mature, and you can find some CNS side effects from that. This will be important when we talk about a drug called clonidine later on. This fits in that same category. So if you've heard of that, keep that in the back of your mind, because this will come up later in the hypertension section. Okay. Anyway, other things you're going to find is that, as we mentioned, with ocular vasoconstrictors, we found that rebound hyperemia. Same thing can happen with these if you had an abrupt discontinuation. It's one thing to note.
Can you explain that one more time? That less than 2 years of age, why not?
Yeah, so essentially what you find is that with young kids, they may have a less developed blood-brain barrier, so you can have potentially some drugs crossing more easily across and causing some CNS effects. What you're going to find from that standpoint is it causes a lot of sedation, and then little kids, you can actually see apnea with it. So for instance, if you had a kid get into clonidine, you can see a lot of pretty significant CNS side effects from that. We'll talk about that a little bit later, though. So, but again, primarily we're liking these because they limit a lot of the systemic side effects, but still they can be systemically absorbed, right? So you do run into that. Anyway, but again, you see sometimes allergic conjunctivitis associated with this. Less common with brimonidine, but still can occur. As I mentioned, limited blood-brain barrier penetration, typically for older, more developed patients. And then we have the carbonic anhydrase inhibitors. These are going to be agents that basically inhibit the enzyme, carbonic anhydrase. Anyone know what the enzyme does? It's going to be, actually, it's going to come up again and again. It's actually going to be something that we'll find in the kidneys is a big place you're going to see that, and the eyes is the other big place. Basically, what carbonic anhydrase does, it will catalyze the conversion from CO2 and water into bicarbonate. Okay, it can then also take bicarbonate and break that down into CO2 and water. Okay. The main point with that being, and I'm not going to show you the big diagram because again it gets overly complicated for our purposes here, but just know that it helps to decrease the production of aqueous humor, basically by preventing things like CO2 and water from getting across in, the cells essentially, right? So just know that it's going to be preventing the production of bicarbonate ions. It's going to be decreasing the fluid transport and the intraocular pressure as well. Okay, so it's working on the fluid side of things. We have two that fit into this category, and again, we'll talk more about this, and then we get talking about the kidneys a little bit later on. But this includes dorzolamide and then brenzolamide. So usually when you see the olamide, you typically think of carbonic anhydrase inhibitor in those cases. Now, this is not used as commonly. Typically, these are going to be a good adjunctive agent, meaning we're going to add it on to something else as a sort of second line sort of thing there. But again, pretty not too bad from an adverse effect standpoint, but just not as effective as something like prostaglandin or beta blocker. And then the last used group we're probably going to be seeing used here is going to be the cholinergic agonists. These are going to be agents that are directly affecting muscarinic receptors to cause meiosis, right? So by doing that, by trying to constrict those muscles there, you're going to find this will help to facilitate the aqueous outflow, okay? So agents that fit into this category include acetylcholine, which we know acetylcholine, yes, that affects muscarinic receptors. That's what our body normally uses to activate those. That is oftentimes used more like in the surgical settings. You see that used occasionally. Other ones that may be used for glaucoma include things like carbachol and pilocarpine. The problem why we don't like these very much is because of the fact that they're going to have very fixed small pupils and myopia, which means that their vision is going to be taking a hit here. This may be okay for patients who may be already blind to begin with, or older patients who are not going to be driving around, things like that. But for younger patients, this is not great just due to that intolerability, right? So imagine not being able to really see much, if you're a younger patient, not good for you, right? And I mentioned we like combination products whenever possible because this helps to limit the number of drops we're having to use. This helps to make it a little bit faster to get the drops in and move on with your life, and we'll get some extra synergy there. So for instance, mixing an alpha agonist plus a beta blocker, mixing those two together, you get, again, more activity, more intraocular pressure lowering effects than just one agent by itself, which is good. And as I mentioned, increased compliance is the other big thing here. Now again, what other drug did I not mention here? Maybe something not over the counter or strictly legal could you use for a glaucoma? Marijuana. We're not going to talk about that here. We'll talk about that more in pain management later on because I'll kind of just have a whole topic on that. We'll talk about all the different things you can use it for. Yes, that does have some intraocular pressure lowering effects. However, it's probably not the first line therapy, but maybe good for patients who have kind of failed other things. They want to use that as an adjunctive that can probably get some additional benefit out of that. Okay. I saw, not to digress too much, but I saw a comedian on Netflix recently, and he was trying to get his green card, right? So trying to get his medical marijuana card in California, and he went to this doctor who only did that, just wrote prescriptions for that, and he was trying to come up with a reason that he needed it, and so he's trying to think in the office, like, what am I going to say? What am I going to say? What am I going to say? And then he was in this office where he could hear everything that was going on in the room between the doc and the patient, and the doc was like, oh, why do you think you need medical marijuana? And the guy was like, oh, I got cancer. He was like, I can't say I have cancer. I'm going to get cancer the next day. I can't do that. And so he eventually gets in the room, and the guy goes, why do you think you need medical marijuana? He's like, my bones hurt. I was like, all right, here you go. And then he walks out, and he hears this guy that goes in right after him. He's like, why do you think you need it? And he's like, I just like the way it makes me feel. He was like, okay, here you go. Didn't need a reason anyway, but anyhow. Okay, so the question is, who do we treat for glaucoma? Typically, if you have a high-risk history and any evidence of increased intraocular pressure, that's going to be your cutoff point there. Some patients are just going to be able to monitor for that and watch for changes in visual fields and things like that. So sometimes you take more of a kind of watchful waiting sort of approach there. Generally, you want to start with a prostaglandin, or if that's not appropriate for your patient based on eye color or things like that, then you can use something like a beta blocker instead. But remember, if you have like a really high-risk like CHF patient, I'm probably not going to be worried too much about their iris color at that point, right? So again, you ought to be weighing the risk versus benefits there. In some cases, you can try one eye first just to see how they tolerate it. Otherwise, you're good to go from that standpoint. And typically, we shoot for around 20 to 30% decrease in pressure. A couple other miscellaneous agents here. We have some ocular anesthetics. Anyone know when we use these?
Like during surgery, like
If they have a foreign body.
Yeah, typically for if you're doing some sort of some kind of procedure or some kind of diagnostic test with the eyes, this is typically going to be using anesthetics for the most part. Two ones we have here include tetracaine and proparacaine. If you see that cane on the end of the name there, that typically is referring to a local anesthetic. The way that all of those work, and lidocaine's another good example, they block sodium channels from propagating action potentials up a neuron, right? So again, you can have sensation being felt in the eye, but if you block those action potentials from going back to the brain, you never really get that signal there. You have no idea that you're even being touched on the eye, right? So we do this a lot for things like tonometry. We'll do this for foreign body removal. If we're doing things like, doing fluorescein stains to evaluate for corneal abrasions, things like that, we'll definitely use that. Only issues, you may see some hypersensitivity, maybe some burning sensation, but again, the eye's going to go numb anyway pretty quick, so you don't really have to worry about that too much. The thing to note, though, is that the eyes are going to remain numb for about 10 to 20 minutes, which means you actually don't have any kind of blink reflex, okay? That means that the eyes can dry out. You may not be blinking. You can get further, you may not feel if you get something else in the eye. That can be problematic. And the problem is that the patient's eyes are going to feel great after that because they don't feel anything. And so this is why we never, ever write prescriptions for this, because if they're self-treating, they're going to say, oh, my eyes feel awesome, it's great, and then they never blink, and then they're just going to go around, and all of a sudden their eyes get even worse than they were to begin with, right? And patients are sneaky, right? They'll go and they see that sitting in the room, and you walk away to go chart something, and they just put that in my pocket, and then you got to be careful with that. Make sure you keep it with you. Make sure they don't have access to it, because again, they'll try everything they can to get some relief there. Right? Never ever write a prescription for this. Only use it in the office. Okay. There's some cycloplegic agents. Anyone know what these do? So basically they paralyze the muscles that will constrict the irises and actually cause dilation of the eyes there. So it causes mydriasis, essentially, is what we're looking for, which is good because it helps us with things like fundoscopic exams and whatnot. And so we will use it most frequently. We'll use some antimuscarinic agents. So just like we saw earlier with glaucoma, we used a cholinergic agonist to cause miosis. We're doing the opposite here. We're blocking the muscarinic receptors and causing mydriasis to occur here. Right? And that gives us a much better view when we're trying to do like an exam. And so the things we're going to use most frequently include atropine, which you're familiar with, like emergency medicine stuff. Atropine is a very prototypical sort of antimuscarinic. And some other ones we use specifically for the eye include things like cyclopentolate and then tropicamide. Okay, so those are used pretty frequently there. The only problem, though, is that you're going to have a lot of photosensitivity, which, why do you think that is? Yeah, because the irises are dilated. You're going to be finding you're just going to get all that light coming into the pupils there. The other thing is blurred vision. It's going to be decreasing the ability to accommodate with the lenses, and so that's why when someone says, "Oh, got their eyes dilated, I need you to come pick me up from the office," it's probably because they can't see anything because their vision is so blurry because of that, right? So again, that's going to be for a couple hours after the fact. So again, if they need to go somewhere, drive somewhere, this is not a good option for them. Sometimes what we use instead is a sympathomimetic agent or something mimicking the sympathetic nervous system, in which case we use something like phenylephrine. Phenylephrine can be applied to the eye and will cause the eyes to dilate by activating alpha receptors, right? And so in those cases, you still see some photosensitivity, maybe some conjunctival hyperemia, but they typically are able to accommodate a little bit better. And so patients typically have less blurry vision associated with the phenylephrine versus something like tropicamide, okay? And the fluorescein is a very good one. This will help us out with staining the eyes to look for things like corneal abrasions or corneal ulcers. It usually comes as a little strip that you can just basically dunk down into the conjunctiva there, and that's actually going to allow it to wash over the eye, and then use like your wood lamp or something that's going to be able to help you determine if there's any kind of uptake of the fluorescein that will help you to diagnose any corneal abrasions and ulcers and things like that. Again, only going to be used in the office, really, when you're doing these exams to evaluate for this. Yeah. And very frequently, if the patient's coming in for something, you're evaluating them for an abrasion anyway, probably you're going to be giving them a topical anesthetic, and so it kind of helps to limit how much irritation that comes along with the fluorescein. One thing I will note here, please always note the spelling of this drug name. I remember I had one doc in the ER who said he spent 10 minutes trying to look for this drug in the system. He kept trying to type in FLO, FLO, FLO. Nothing would come up. I was like, it's FLU. And he goes, oh, there it is. I don't know. EMRs are not good with Googling names. They can't be like, did you actually mean this? They only kind of pull up stuff. I don't know. He's an older guy, so you give him a break. But that's why you have pharmacists around, right? He can help you with spelling all kinds of things. But yeah, so it's one of those things where actually was slowing him down pretty significantly from seeing patients because he couldn't find the kind of drug he's trying to look for, right? Anyway, so any questions on the ophthalmology stuff? All right, so let's move on. We're going to move into the ENT.